Hi, I'm doing my project on the Mental Health Parity and Addiction Equity Act. The purpose of this presentation is to examine the Mental Health Parity and Addiction Equity Act, to understand how the policy affects behavioral health treatment, apply the policy to a fictional case based on my clinical experience at my internship, and discuss future implications for social work practice. So the policy background is that it was passed by Congress in 2008 as a federal law, and it requires insurance plans offering behavioral health benefits to provide coverage comparable to medical and surgical benefits. It includes medical health and substance use disorders. The goals are to reduce discrimination against behavioral health care, improve access to mental health treatment, reduce financial barriers, require equal copays, deductibles, and treatment limits, and improve early intervention for clients. My case example is a 17-year-old female who presents with depression, substance abuse, incarceration, anxiety, disordered eating, bipolar, and lots of anger. This policy directly affects her because we have to get a certain number of days approved by insurance, and if we can't get those days approved, then she can't be at our treatment facility, and she needs to be at our treatment facility, especially since if she can't be at our treatment facility, she will go back to jail. It's very important. Qualification for services. How MHPAEA helps clients. Because of her family's insurance, it covers behavioral health. Residential treatment must be evaluated similarly to medical treatment. Insurance cannot simply deny care because it's mental health. She needs it. It's essential. Financial requirements must be comparable to the medical care that the insurance provides. The challenges. Managed care barriers. Despite parity, prior authorization, medical necessity reviews, limited provider networks, few residential facilities accept insurance, and the reimbursement rates. The impact of this policy is that the positive impacts are increased chance of approval, lower financial burden, greater recognition that mental health illness deserves treatment. The negative impacts are delays, appeals, limited provider availability, and struggles to find care. An audience question that I would like to ask is for everyone to think about this. Should insurance companies be allowed to deny residential mental health treatment if a physician believes it's medically necessary? Improved outcomes. How these changes help my client with the fake name, of course. Earlier treatment, fewer hospitalizations, reduced self-harm, better family functioning, and greater long-term recovery. My future role as a social worker, I will advocate for clients during utilization reviews, which are calls with insurance, help families navigate insurance, collaborate with treatment teams, educate families about their rights and their insurance, promote equitable access to behavioral health care. Why this matters. MHPAEA demonstrates that equal insurance coverage is only the first step. Social workers play an essential role in helping clients overcome ongoing barriers created by managed care. Conclusion. Takeaways. MHPAEA reduced discrimination in insurance coverage. The policy improves access to behavioral health treatment. Managed care barriers still exist. Social workers are critical advocates for improving access. Thank you, everyone, for watching.